Hello, this is Kim Jong-il. Today, we will cover a case using expansion appliances. This is a 21-year-old adult male patient. CC is anterior crowding. How does the lateral view of the photo look? The appearance of the face is not aesthetically bad. As in this case, there are cases when the patient is satisfied with the current appearance and wants the lips to no longer retract. The third molar has already erupted. Tooth number 26 has undergone root canal treatment. Let's look at the PA-CEF analysis. There is no big difference between left and right. However, the midline of the maxillary arch moved slightly to the left. The maxillary arch is a little narrow. The buccal sides of the left and right maxillary first molars are parallel, and the mandibular anterior teeth are crowded. The midline is slightly deviated, and the canine key is class 1. You can notice that tooth number 25 is smaller than tooth number 24. Let's look at ODI, APDI, and CF. Please pay attention to the palatal plane angle and AB plane angle. ODI is 69.5, APDI is 4.5, and ODI is 74. APDI is 82. Combination factor is 156. This is a class 1 low-angle case. Have a look at the E-line. E-line to UL is 0.1. E-line to LL is 1 mm. The lips are not protruded that much. Once again, this patient is a class 1 low-angle case. The FMA is large at 33 degrees. U1 to lip line is 2.2 mm, UOP is 12.6, POP is 9.3 degrees. They are in almost normal range. U1 to FH is 113, IMPA is 94, IIA is 119 degrees, which is almost normal. This patient is not unaesthetic. The patient also doesn't want his face to change. How should we treat it? Non-extraction treatment is required. There is anterior crowding. The third molar has already erupted. Either we should extract the third molar, or if the maxilla is narrow, we should widen it. The problem with treating this patient with non-extraction is that while leveling the mandibular anterior teeth, the lips may be slightly protruded. On the other hand, the problem with treatment with premolar extraction is that the narrow maxillary arch can become even narrower. The combination factor is large at a 155. If the premolar is extracted and the wisdom tooth is extracted, the patient will lose 8 teeth. U1 to FH is 113 degrees, showing a normal value. Posterior available space distance from distal surface of maxillary and mandibular second molars to ramus anterior border, or PNS. In this patient, the third molar has erupted, so we can gain some space after extracting the third molar. After explaining a little asymmetry, you can either pull out only 4 third molars or 4 maxillary second premolars. Because this patient's face is not unaesthetic, only the third molar is required to extract. How should we treat it? Many want to expand maxilla by using MARPI and to move entire mandibular anterior teeth backwards. Because the patient has narrow maxilla and is adult. However, this patient doesn't show a posterior crossbite. The lateral tooth group is also not crossbite, but the maxilla is a little narrow. In this case, you can use SMEs and do strategic leveling. Basically, in mio-orthodontic treatment, we do strategic leveling first and apply mios at the final stage. To make this strategic leveling even more efficient, expansion appliances can be used in the maxilla and mandible. You can use SME for the maxilla and Schwartz for the mandible. At the same time, strategic leveling enables more efficient treatment. This patient used an expansion device on maxilla and mandible. There is an Adams clasp on tooth number 4 and number 6. Screw was turned twice a week. Then attach the bracket to the maxilla. Adams clasps should be removed from maxillary tooth number 14 and number 24. The crowding of the anterior part of the maxilla must be resolved quickly. I use strategic leveling for this. Expansion appliances can be used as an auxiliary for strategic leveling. Now patients wear the device only at night and turn screws on maxilla and mandible twice a week. You can notice that the maxillary arch is somewhat wider. I start attaching brackets to the mandible. At this time, tooth number 33 and number 43 have a slight crowding. It is better to attach the brackets later on these teeth. If you attach only tooth number 1, number 2, number 4, and number 5 first, and then attach number 33 and number 43 later, you can minimize the amount of labioversion of the anterior teeth. We should form the maxillary arch with proper form. Then attach the bracket to tooth number 7 and use an open coil spring, and attach the bracket to tooth number 6 and insert the meos. The treatment process is simple. You can use an expansion appliance to efficiently resolve anterior crowding. This is a picture after treatment. The anterior crowding has been resolved and the maxillary and mandibular arches are slightly expanded. The third molar tooth, which was on the X-ray before the treatment, was extracted. Since this case was a class 1 relationship, the mandibular second molars were slightly uprighted. The front and lateral views of the face have not changed significantly, and the smile has become more natural. Treatment took 1 year and 3 months. Combination factor does not change. The mandibular incisors were slightly proclined. As mentioned previously, it is recommended to attach brackets to the mandibular canines later. It is the superposition of the CF pre and after treatment. Significant changes pre and after treatment are not shown in the CEF. First, I use the expansion appliance first. Then, attach brackets to the incisor and premolar using the expansion appliance. Then I derotate the terminal tooth. After leveling the anterior part, I use an open coil spring on tooth number 6. This is what strategic leveling is. Attach the bracket to tooth number 6 and insert meos. Again, apply strategic leveling with fixed appliances and meo at the finishing stage. Strategic leveling is to achieve uprighting and parallel rotation of the posterior teeth after leveling the anterior part. At this time, leveling the anterior part by using an expansion appliance will shorten the treatment period even more and minimize proclination of the anterior teeth. That is, level the front part first using the expansion appliance and stop wearing the expansion appliance when using the open coil spring on tooth number 6. Let's take a look at the clinical control of the expansion appliance. We turn the expansion appliance screw twice a week. I ask patients to wear the appliance all the time except when eating and brushing, and make an appointment in 4 weeks. At the next visit, first check whether there is any space in the maxillary arch. If there is space in the maxillary arch, attach a bracket to the maxillary tooth. Brackets are usually attached to tooth number 4 or number 5 on the left and right side. Cut Adams clasps on tooth number 4, or transform them into ball clasps. The appliance is worn only at night and lets the patient rotate the expansion appliance screw twice a week. If patients visit, it will be 2 months after the appliance is applied. 2 months later, the mandibular anterior teeth will also have space. Attach the bracket to the mandibular anterior teeth. You can either let the patient keep wearing it or stop wearing it. If necessary, the appliance can only be worn at night and the screw can be turned continuously. By the next month, the anterior crowding would have been almost resolved. At this time, attach the bracket to the terminal tooth, use the OCS, and stop using the appliance. I hope you remember this process. Thank you for watching.